Good afternoon, everyone. I am Dr. Devender Bairwa. I finished my DM in clinical immunology and rheumatology this year only from Chipper. Previously, I was working as senior resident so there in medicine, and I'm an MBBS student from MC New Delhi. So today we'll be discussing this topic, osteoporosis. Sanket, can I start or like should we wait for the
We can
students?
start, Devender. We can start.
Okay, can start.
Yeah.
Okay, okay. Thank you. So we'll start. Before starting this topic of osteoporosis, we should understand why this topic is so important and why we are discussing it today. So, so how many of you are familiar with this photo and with this picture? You can, I think, you can comment on this. I think chat is there. Okay, so this picture is from that movie Ghatak, and the dialogue which was associated with this was that कुत्तों का सहारा वो लेते हैं कात्या जिनकी हड्डी में पानी भरा होता है. So the reason why I put this photo here is just to make sure that you understand that bone quality matters. And that's why osteoporosis is disease of a this is simplest definition of osteoporosis. Porotic bone, porous bone, bone which is weak, bone which is abnormal in quality. So we'll be discussing this presentation under these headings. We will discuss about osteoporosis, its definition and measurement, then its epidemiology, its pathogenesis, diagnosis, approach to patient, and treatment. This glucocorticoid-induced osteoporosis we'll be discussing in separate class as a separate topic. So, coming to definition, osteoporosis is characterized by low bone mass, microarchitecture deterioration, and increased susceptibility to fracture. It means reduction in bone strength leading to increased risk of fracture. Now, currently, we are defining this osteoporosis on the basis of bone. Define it like if BMD T scores is more than -1, then is normal. If it is between -1 to -2.5, it is taken as osteopenia or also known as low bone mass. And if it is less than -2.5, then it is taken as osteoporosis. And if there is associated with reduced BMD less than -2.5, then we can call it severe or established osteoporosis. Now, T-score reference point is actually 30 years old white female. So why I'm emphasizing on white female, because if you see has been generated from literature and reference point that they have taken white female. It means we do not have our country specific data for this thing. Then up to what point we can use G-score? G-score is used less than 50 years of age. What this T-score and G-scores are, we will discuss further. Although I can tell that G-score is on the same age and T-score is taken reference point from the 30 years old white female. So why we are bothering about this BMD so much? Ultimate idea of studying osteoporosis is that we have to prevent fracture in a patient. And if we see that bone quality, including BMD, is not the only risk factor for fractures, because there will be some other risk factors and there will be risk factors for falls. All these will accumulate together and then fracture will happen. So even if we are reading about BMD, even then we are missing so much. So what are the fragility fractures? You should understand that fractures which occurs with minimal trauma or fall from less than fragility fracture, and they are the feature of exceptions: fingers, toes, face, and skull, when they are injured even with trauma, are not generally taken as fragility fractures. So this definition, if you see, WHO defined osteoporosis in 1994. That means before 1994, there will be some other methods to diagnose or to see or just their names and some. So older definition, earlier than this BMD definitions, there was a term known as metacarpal index. They used to have this metacarpal index, in which what we basically see this called that will be taken from the outer margin, the inner, and they will measure it. So it was not standardized kind of thing, but they were using either single metacarpals. At that time, they used to have it, and at that time, metacarpal index will be used for osteoporosis. Other one thing was Singh index. In the Singh index, it was actually based on trabecular patterns of the proximal femur, and they classify osteoporosis into 6 grades. So can you see this is the normal pattern? So grade 6 was normal pattern, and as it uses, then grade 5, grade 4, grade 3, grade 2, grade 1. Grade 1, grade 2, these are severe osteoporosis. So these were rough methods that those were being used at that. Currently, we had this BM definition, and after 1994, we are using only BMT T scores for defining osteoporosis. So coming to epidemiology, so types of osteoporosis, if we see, osteoporosis can be divided into two parts. One can be primary osteoporosis, that there will be no any underlying cause, or they will be mostly related to age and menopause. 95% cases will be men, and only 5% of men will be having this kind of osteoporosis. Then there are secondary osteoporosis. There will be some underlying cause like systemic disease or drug intake, history of steroid intake, anticonvulsant, or there can be some malabsorption, celiac disease, something else will be there, RA will be there. These are secondary osteoporosis. And 5% cases in women and 30% cases in men are seen. Coming to fracture, if we see there are two peak ages of epidemiology of fracture. If the young people and old people, generally young people when fractures are occurring, they occur mostly in base during some sports injury, something like that. Mostly traumatic, high impact injury will be there, and it will affect more, or maybe tibia or the forearm, both bones. In old people, mostly they will occur after trivial trauma, and mostly vertebra, hip, and forearm will be affected. Now, this high impact injury, nowhere it is defined what is the cutoff for high impact injury. It's a common sense. If there is too much force involved, too much speed involved, too much momentum involved, then those are mostly high impact injury. And trivial trauma is any trauma which should not result into injury, is taken as that. So, if we see fracture, factors leading to fracture, if we see, so low bone density is required along with other factors like propensity to fall and poor bone quality. All these will result into a fracture. For low bone density, there can be low peak bone mass depending on, or there can be increased, can be because of aging, menopause, or other risk factors. And there is decrease of one T score of one G score, one T score of BMD, then there is approximately 1.5 to 3 times increase in risk of osteoporotic fracture. If we see lifetime risk for osteoporosis of age, it is higher in females, roughly 50%, and it is 20% in males. Peak bone mass that we are achieving in our life is at 30 years of age, and then it remains like this for 10 years, 32 years of age. So my peak bone mass I have achieved 2 years ago. And till 40 years of my age, my peak bone mass will be maintained. And then every year, 0.3 to 0.5% it will fall. In case of females, when they attain menopause, at that time, for the first 7 years, that rate increases to 10 times, to 5%. For those 7 years, there will be so much rapid decline in bone mineral density, and then again they will have the rate of 0.3 to 0.5% per year. Because the rate of this BMD loss is so much increased during postmenopausal state, those early years, that is why risk is substantially increased. And we will see that these in those interventions, HRT, hormone therapy, and other things will work better if they are started earlier in menopause. So this figure is from Harrison only. If we see, this figure is showing incidence of the vertebral fracture, Colles fracture, and hip fracture. We can see there are age groups starting 35 and then 85. So if we see in this age group, we can see that Colles fracture is higher and then subsequent uses. And age, there is increase in hip fracture, so much so that in very old people, most common fracture is hip fracture. hip fracture. So this is what is mentioned in Harrison is that because of the mode of fall, the way they are falling, like in the younger, relatively younger age group, people generally they tend to fall on their arm, on hand, front side, and when in the uh, fall backwards or sideways. In this way, the hip fracture is higher in case of very old age group. Coming to fracture related mortality, fracture might increase mortality in some kind of fractures. Like if we see hip fracture, in hip fracture, the increased mortality can remain elevated for 10 years. 75% of this 75% of this increased mortality is attributed to underlying illness, like they must be having some COPD or maybe heart disease, something will be there, and 25% is attributed to complication like wound or delirium or thromboembolism, etc. Mortality at 1 month is 10% and 30% in 1 year. This mortality is actually very high. If suppose there are three old ladies they're having this fracture, then one of them will die at 1 year. That is actually a high mortality rate. Then come to vertebral fracture. In case of vertebral fracture, risk can be elevated for next 5 years. And forearm fracture only in old men has been seen with associated increased mortality. So these fractures are associated because of osteoporosis, but they have been shown to increase mortality in these patients. This table is from one textbook, which is showing secondary causes of osteoporosis. If you see all mentioned in your book of your, and there they have mentioned like underlying cause of osteoporosis and drugs associated osteoporosis. Generally, all these are associated osteoporosis, and they can be taken as secondary causes of osteoporosis. We will discuss again these all causes in subsequent slides. So, and remember, these are the factors for osteoporosis, and there are some other factors which are responsible for osteoporotic fracture. So this is a table from Harrison, which is showing presence of showing factors for fractures. So there we can see non-modifiable fractures, and there we can see potentially modifiable fractures. Factors for in case of non-modifiable, we can see personal history of fracture as an adult, history of fracture in first relative, female gender, advanced age, wide race, and dementia. In case of potentially modifiable factors, we have current cigarette smoking, estrogen deficiency, in like early menopause, or there can be a low calcium and vitamin D intake. There can be a lot of alcoholism, impaired eyesight despite adequate correction, recurrent falls, inadequate physical activity, poor health, and frailty. So there will be MCQs in most of your papers where they will ask you specifically what is the risk factor for osteoporosis and what is the risk factor for osteoporotic fractures. See these tables carefully because they'll be important for you. 20% of women will have a second fracture within 2 years. That's why they have given this personal history of fracture as an adult. If somebody is having fracture already, then they have increased risk of fracture subsequently in future. Risk diminishes to less than half of those rates in the subsequent 3 years. It means for the first 5 years there is increased risk. 2 years there is a 20% risk, and then there is a 10% risk for 3 years, and then it declines to baseline thereafter for most fracture types, though risk after a vertebral or hip fracture may persist a bit longer. That means there is always some increased risk of fracture in these patients who already have fractured in the past. So we have discussed these factors for osteoporosis fracture. Now we can see what are the protective factors against osteoporosis. So greater height, greater weight, greater muscle strength, increased dietary calcium, greater physical activity, later age at menopause, and hormone replacement therapy after menopause. All these are factors which can prevent against osteoporosis. So coming to pathogenesis, as we already discussed about peak bone mass at early 20s in females and mid 20s in males is achieved. By 30 years of age, there will be peak bone mass and there will be a steady state. In case of males, there will be a 10% more bone mass due to androgen-mediated periosteal apposition. That is the reason why males have more bone mass. But understand this, estrogen and androgen both are involved in this periosteal. Even in males, estrogen is rate of bone mass. If we see already peak bone mass at 30 years of age is achieved, then 10 years, it will be steady state, and 0.3 to 0.5% per year fall will be there. And at menopause, rate will increase to 10 times, that is 3% to 5% per year for the next 7 years. This is a time where is so much decline in PMD. And then again, they will be returned to 0.3% to 0.5% per year. There are four ongoing processes in bone, which is always. So first thing is growth. Generally, bone grows either by membranous or in chondral bone formation. This growth of bone generally occurs in developmental stage, like fetus is developing or when baby is developing. Then it occurs. Then there is bone modeling. Formation and resorption occurs on the same surface at different times. In case of remodeling, formation and resorption occurs on the same surface at same time. And this is the principal metabolic process in adults. That means in case of adults, there is less of growth and modeling, but there is lot of remodeling. And there is repair. Repair generally occurs when there is a fracture. There will be formation of hematoma and site of fracture in days. There will be formation of a cartilaginous callus within weeks. Then there will be intermembranous ossification with primary bone formation within months, and secondary bone will keep forming for years. So in case of adults, it is the remodeling which is a principal process. So much so that whole skeleton is remodeled every 10 years in adults. So this figure is from Harrison only, and let's see what showing. So basic multicellular unit. They have also mentioned in Harrison basic molecular unit, but everywhere in other books they have mentioned like basic multicellular unit. So what happens at the site where bone has to be formed? See, in case of bone, you have to some bone, then you make some bone. Destroy some bone, then make some bone. Idmari, like this only the bone will form. So what happens when there is formation of basic bone, where bone has to be formed? So there will be a ton of pre-osteoclasts because of cytokines and other signal. Once pre-osteoclasts are there, they will form osteoclasts, and osteoclasts will form osteoclastic giant cells, and they will eat the bone. Then there will be formation of this resorption pit will be formed, and then there will be this pit will be formed, and then side by side, osteoblast will be there forming this osteoid, that bone matrix, and also osteoid, and then bone will be laid down. So what happens at one end, if you see here only, this osteoclasts are dissolving bone, and then osteoblasts are making bone, and this process will keep going, keep going, keep going. And what will happen? Those osteoblasts which were involved here for making bone, they will become flattened, less metabolically active, mostly dead. Some will be living only, and they will form osteocytes. And these osteocytes will work as mechanosensory cells for bone later on. And wherever bone has to be formed, there will be harmonious activity of osteoclast with osteoblast. Pathogenesis of bone loss. Generally, there is osteoclast activation. There is formation of BMU, that is basic multicellular unit for resorption of bone. Osteoclast mediated bone formation. Osteoblast mediated bone formation is there. Osteoblast to osteocyte transition is there. And when osteocytes are formed, they actually release a lot of sclerostin. This sclerostin is kind of molecule which is released by these osteocytes, and it actually inhibits bone forming pathways. When we do not access, when there is no much mechanosensation in osteocytes, there is increased sclerostin. And this sclerostin actually inhibits bone formation. So what happens when we do exercise, when there is mechanical loading on the bones, because of this mechanical loading, osteocytes are activated. They know that load is there, then they will release less sclerostin. Less sclerostin means less inhibition of bone formation. Less inhibition of bone formation means more bone formation. That is how exercise actually, one of the ways, can help in maintaining your bone mass. So coming to predictors of bone mass, what are the factors? These are also will be counted as factors responsible for fracture. So there are lots of genetic factors, including there are there will be genes involved in things like this WNT pathway is there, rank ligand osteoprotectin pathway is there, and chondral ossification pathways are there, and then vitamin D and parathyroid pathways are there. So genes in these pathways, if they have single nucleotide polymorphism, some mutation, something is there, there can be effect on bone mass. Monogenic osteoporosis, this is generally asked LRP5 mutation. LRP5 function we will see in subsequent slide. It can lead to osteoporosis pseudoglamous syndrome. Apart from genetic factors, there can be ethnic differences as blacks raise a greater bone mass. Then nutrition intake, if calcium and vitamin D against bone mass loss, and if it is deficient, there will be increased risk of osteoporosis and fracture. Exercise, high impact exercise will give high bone density. So this is the reason why this gymnast will have highest bone density, because they are involved in high impact exercises. The gymnasts have the highest bone density, followed by runners, followed by swimmers, and followed by cyclists. So if you want to improve your bone mass, then go for either running or swimming. Gymnast, I don't know whether we can do it. Then bundle functions, because as we have seen, hormones are important, specifically estrogen and androgen. They also have been maintaining bone mass. And bundle function hormones are like estrogen and androgen are there. Then if we see predictors of bone loss, all these factors which are there for as predictor of bone mass, they are actually involved in bone loss also. There is deficiency of these. And all these factors that we discussed, plus alcohol, smoking, of secondary causes of osteoporosis, as mentioned in Harrison or in the table that I shown, all these are predictors of bone loss. So this figure is from Harrison only, and if we see, this figure is showing what is going on there in the bone and how bone is lost in case of osteoporosis. So see figure 8 and just see here, these red, white kind of things are osteoprotein. This cream color dot is rank ligand, and then the blue thing is rank. So understand this. Generally, what happens? This rank ligand has to bind with rank. This is how signal transaction is occurring. So generally, these osteoclasts will be having this rank receptor, and this rank ligand is produced by different cells. If we can see here, T lymphocytes, activated synovial fibroblasts, and then these dendritic cells are there. Happens once this rank ligand is released and it bind with this rank receptor over developing osteoclast, signal transduction is happening, and then it helps these osteoclasts to grow, and then they become activated. This osteoprotein natural inhibit this rank ligand and rank receptor, because it competes with rank ligand to bind with rank. Now understand this activated synovial fibroblasts, activated T lymphocytes, why they are important. If you understand this patient of rheumatoid arthritis or other inflammatory arthritis, if you see there is rapid bone loss is there, erosions are formed. All these are because there are so many activated T lymphocytes in that synovium pannus, and they keep producing this rank ligand. And this is actually a branch of discussion nowadays known as osteoimmunology, where these cells are actually involved in case of uh, bone formation and bone resorption. So this is happening, and then if you see, if there is increased rank ligand, there will be more bone loss. If increase osteoprotein, then it will be good. There will be less of rank ligand and rank interaction, and that's how less of osteoclast will be activated. Now see down here what they have mentioned: pro-resorptive and calciotropic factors, and there they have shown anabolic and antiresorptive factors. Now, vitamin D, PTH, PTHRB, PGE2, IL-1, IL-6, TNF, prolactin, oncostatin M, and leukemia inhibiting factor. So all these they have mentioned will increase disruption of bone. And there here we have seen estrogen, calcitonin, then bone morphogenic protein 2 and 4, transforming growth factor beta, thrombopoietin, IL-17, PDGF, and calcium. So now this understand this IL-1, IL-6, and TNF increase in case of inflammatory arthritis or where there is joint, where this inflammation in joint, and all these actually augment this rank ligand and rank interaction. Estrogen actually reduces this rank ligand and rank interaction. Estrogens also indirectly inhibits IL-1, IL-6, and TNF. And remember, the important form of receptor in bone is estrogen receptor alpha, through which it is working. So we will see because of all these molecular involvement, we have got many pathways so that we can provide drugs. So one is like denosumab. This denosumab is nothing but it mimics osteoprotein only. It is a antibody which will be binding with rank ligand, and then it will inhibit rank ligand, the rank interaction, and that's how we are using this drug for treatment of osteoporosis. So coming to bone formation pathways, these pathways are not given in Harrison. Just see this, understand this once. So there is one Wnt pathway. Wnt4 binds with LRP5 and Fizzle protein. This LRP5 is the same thing that we were discussing during osteoporosis pseudoglioma syndrome. So Wnt4 will actually bind to LRP5 and Fizzle protein, and once this pathway is activated, there will be osteoblast proliferation and there will be reduced rank ligand. This is the result of this thing, and it will lead to more bone formation. This pathway is generally inhibited by sclerostin or soluble Frizzled-related protein or DKK1. This DKK1 you will also read when you will read about epidemiology, and this sclerostin we already discussed. This is produced by osteocytes when there is less of mechanical load, and that's how it can inhibit bone formation. The other pathway which is there is this BMP pathway, where this bone morphology they bind with BMP receptor. BMP2 and 4 are important in bone, and then it will also lead to osteoblast proliferation. And this is actually inhibited by noggin. This noggin is important in case of formation of osteophytes in case of spondyloarthritis. You will read this in immunology only. So these two are the bone formation pathway that you need to know. And this sclerostin, as we came to know, then we have devised this antibody against this sclerostin known as romosozumab, and now it is approved therapy for osteoporosis. So what is the aftermath of this thing when there is so much bone loss? As we see, what happens, this bone loss depends on surface, because osteoclasts they need surface to attach, and that is the reason why trabecular bone, which is having more surface, is much more involved. The reason why there is involvement of vertebrate, because they contain high trabecular bone. Similarly, that hip also contains high trabecular bone. So what happens, if you see, this is how normal bone appears. And when there is a osteoporosis, there is loss of these interconnections, and all this is lost, and then we can see this thing. If you see in this figure, normal figure, the length of this trabecular bone is supported by interconnections. But once there is osteoporosis, there will be less of connection, and so much so that there will be increase in the unsupported length. So what happens, this actually a mathematical formula. If the osteoclasts penetrate trabeculate, they leave no template for new bone formation to occur, and consequently rapid bone loss ensues and cancellous connectivity becomes impaired. As far as when they surface, some bone can be formed. Once, because of increased osteoclastic activity, if all surface is gone, there can be no remodeling, because you know remodeling is the main pathway through which the bone is being formed in case of adults. Now, what happens? According to Euler's theorem, the buckling load of a weight beam increases inversely with the square power of its unsupported length. This is the formula. So what if unsupported length is increased? There will be increased buckling. Increased buckling means it cannot sustain the load. It will fracture easily. So this is the math behind your fractures. The loss of equal to trivial trauma fracture. So going further for calcium and vitamin D, I would like to show you this slide. This slide is showing briefly about metabolism of calcium and vitamin D. See this slide carefully, because it's a flow diagram, and it is actually important because it will help you understand endocrinology as well. So now see, in the body, serum calcium is important. Serum is high, body has to take action. If serum calcium is low, body has to take an action. So generally what happens when serum calcium is there, either vitamin D or PTH has to take care of that thing. So generally acutely when there is hypocalcemia, PTH works. Once PTH is able to maintain calcium, body gets enough time to understand what is going on, then vitamin D will come to action. So let's see. So generally vitamin D2 and D3, they are actually activated in liver partially by 25 hydroxylase enzyme. There is formation of 25 hydroxy vitamin D. And when this 20 vitamin D is formed, then in the kidney, by action of 1 alpha hydroxylase, formation of 125 dihydroxy vitamin D, which is the active form of vitamin D. So before formation of this vitamin D, PTH was taking care of serum transiently. Once 120 then equals PTH, you rest. I'll take care of now. Picture. So PTH actually because it cannot sustain it for more for longer time, and it wants vitamin D to come into picture. So it increases activity of this enzyme, and once this 125 hydroxy vitamin D is formed, it will tell PTH to rest because now vitamin D will take care of this thing. If you understand, vitamin D actually increases calcium absorption as well as phosphorus absorption from gut. This is how it increases calcium level, and it takes time. That's why PTH is the first opening batsman in this picture, and then vitamin D comes to picture. Uh, if there is increase in serum phosphate for any reason in the body, for any reason, XY reason, then there is increase in FGF23. Once FGF23 is increased, what happens? It actually inhibits PTH as well as it inhibits 1 alpha hydroxylase. FGF23 will also inhibits transport of sodium along with phosphate. Sodium phosphate co-transport activity will be reduced, and then there will be less of phosphate resorption. PTH also inhibits this thing because PTH also is actually a phosphaturic hormone. So why I told you all this, because now understand this. What happens? Vitamin D is good overall if you see. PTH, if it will be chronically activated, then it will lead to hypocalcemia because of increasing. It will if PTH is increasing, then there will be weakening of bone. So this is important because calcium and vitamin D both are required for bone formation, and if there's deficiency of calcium and vitamin D, then there will be increased risk of osteoporosis. Now, there's a caution, like what they have told in Harrison, that recent studies have suggested that there may be differences in safety based on calcium source. High intake primarily from supplement sources appear to result in greater risk of renal stones and perhaps cardiovascular calcification, although the literature is inconsistent and controversial. So what they want to say that calcium that we are taking from Shelcal or calcium carbonate tablets is maybe having increased cardiovascular calcification and increased risk of stone, although the calcium from milk and some natural vegetables is safer. But literature is controversial, but this point is still there. So coming to effect of estrogens, some of these already we discussed. Let's see. Loss of estrogen increases production of rank ligand, reduces production of osteoprotectin, increasing osteoclast formation and recruitment. So if there is more osteoprotectin, less of rank ligand, less of it also enhances lifespan of osteoblast. Main effect is through estrogen receptor alpha type. Then they also reduces lifespan of osteoclast. It enhances bone remodeling even more than even androgens in case of males. Enhances activity of IGF, that is insulin-like growth factor, and TGF beta, and it also inhibits IL-1, IL-6, and TNF alpha indirectly. Estrogen will be helpful. So all these are ways through which estrogen is working on bone. Coming to physical activity, athletes have higher bone mass than non-athletes, that we already know. More effective before age of puberty. So what happens? This peak bone mass, when it is being achieved, once you achieve peak bone mass, after that the effect of physical activity is actually less important. So what can happen? Somebody achieves peak bone mass and then they are involved in physical activity. It is possible to stop somehow, to retard somehow the loss of bone, but bone mass cannot be increased. But before puberty, it is quite possible to increase your achieved peak bone mass if you are involved in physical activity. In adulthood, like 1% to 2% mass in short-term studies, people have seen only studies 2 years and only this much increase in bone mass. Active individuals are less likely to fall and more likely to protect themselves. This is the other way through which physical activity can be helpful. So because for fracture to occur, there has to have low BMD, there has to have risk of fall. People who are physically active, their reflexes are good, less prone to fall, and they're less prone to get injured and have fractures. And also, studies have shown that physical activity actually slows down cognitive decline in older age. If somebody have dementia, they will have high chances. If somebody doing exercise for regularly, then there will be less of cognitive decline, less of dementia, less risk of falling. So these are the various ways through which physical activity can actually reduce the chance of osteoporosis and osteoporotic fracture. So this is table from your Hyson. This is a partial part of the first table I showed you in the beginning. This table is showing disease associated with increased risk of generalized osteoporosis in adults. So mostly, if you see, there is either some defect in case of your or there is some endocrine function or some disease. Uh, and include hematologic disorders. Then there are selected inherited disorders, and then the other disorders. So just see this because there are many causes. Sometimes there will be many MCQs asking for what is the not the what is not the cause of osteoporosis. In Mari there will be something. Then drugs are there. Glucocorticoid, the most common cause of secondary osteoporosis. Glucocorticoid is also the most common drug causing osteoporosis. Apart from steroids, cyclosporine, cytotoxic drugs, anticonvulsants, inhibitors, SSRIs. Then thyroxine accessory therapies, aluminum specifically is associated in case of CKD patients. Antagonists, gene agonist, heparin, lithium, PPIs, androgen dependent therapies in case of cancers, and thioguanidine diode like in case of diabetes. So these all drugs are implicated in case of increased risk of osteoporosis. Coming to smoking, so there is that toxic effect of smoking on osteoblast. Apart from that, there can be indirectly by modifying estrogen metabolism because if you see females who smoke, they have 1 to 2 year earlier attainment of menopause than general population. Then there are secondary effects of smoking, which indirectly increase risk of osteoporotic fracture. Like there can be intercurrent respiratory illnesses, there can be frailty, decreased exercise, there can have poor nutrition, and they can have intake of steroids. So all these will culminate into increased risk of osteoporotic fracture. So coming to clinical features, in case of non-spine, generally we see there will be a low trauma fracture like fragility fracture, trivial trauma fracture. High impact fracture like during running, skiing, skating, or playing sports should not be counted as low trauma fracture, although there is no clear distinction. So what this line means? This line means that although we know that likely not to be because of osteoporotic bone, but there is no clear-cut demarcation. Because if you see patient having osteoporotic bone, if they have low impact injury or high impact injury, they will have fracture anyhow. To use your clinical judgment for that. Then sideways falls lead to hip fracture, or if patient sits down on their hip, then they only also then it will lead to hip fracture. They fall backward, then hip fracture. In case of spine fracture, if there is a unexplained new lower or back pain which aggravates the movement and relieves on lying supine without any radiation, some patient may have rest pain. All these can be features of a hidden vertebral fracture. There can be loss of height. Generally, in case of men, 3 centimeter. In case of women, 4 centimeters, taken a significant height loss. Then kyphosis of thoracic spine can develop without any pain. You must have seen many patients coming to your OPDs. Old ammas will be there. They'll be having this kyphotic thoracic spine, but they don't know what has gone wrong with that. There can be loss of lumbar. There can be localized or diffuse spine tenderness, or there can be restricted mobility. Now, try to understand that if suppose some patient is there and patient's spine is kyphotic or let's say scoliotic because of any kind of uh, this kind of fracture, what happens? There can be non-specific musculoskeletal pain in these patients, and that is what happens. Let's say some old amma is having 3 or 4 vertebrae fracture. So what will happen? There can be deformity, and deformity can lead to this all these ribs on one side can actually touching this pelvic bone. That can happen, or there can be abnormal posture. All this will lead to abnormal spasm and strains on these muscles, and then that will lead to non-specific pain. Mean fracture, but that will be there only. So that can be there. Apart from this spine fracture, there are other causes of vertebral deformity that you should know, because you see somebody's deformed vertebra, you should not think of fracture or of osteoporosis only. There can be fracture, but there can be fracture because of trauma. Apart from osteoporosis, there can be malignancy, infection, and metabolic bone diseases. Apart from that, important causes are Paget's disease, spondylosis, scoliosis, and Sherman's disease. Sherman's disease is a kind of osteochondrosis. So what happens, if you must have seen many uh, pubertal, peripubertal males who will achieve excessive height in short span of some months, and because they have got so much growth, what will happen? They will have appearance of some hump in their back. That is because their spine has grown in a short span of time, and with time it actually improves. So this is known as osteochondrosis of spine. That is actually a benign condition. It improves time. So all these are causes of vertebral deformity that you should be aware of. Then there are stress fracture. Generally, these are fracture where damage outrun repair. It can be either fatigue fracture or it can be insufficiency fracture. Subjects with high level stress, like military recruits or athletes, when they are using, like going for march daily for prolonged hours and everything, then they will be having fractures. Insufficiency fractures, intrinsically weak bone can't handle normal stress, generally seen in case of pelvis and spine. These all can also be associated with osteoporosis. Then, what are the predictors of mortality? Not all fracture will increase the mortality, but there are some factors like male gender, coexisting illness, poor functional status, smoking, and all these are factors which can increase mortality apart from the type of fracture that we already discussed. What are the morbidity associated fractures? There can be persistent chronic back pain. There can be height and kyphosis. There can be because of this height and kyphosis. Loss of height and kyphosis, there can be accuracy decline because thoracic cavity shape will change, maybe volume will change. It will lead to less of accuracy. GRD can be there because of reduced tone of lower sphincter of esophagus. There can be constipation and abdominal distension and cosmetic issues associated with these things. Then there can be poor functional quality of life. Generally, this QLFO, it's an instrument questionnaire that people use to look for the quality of functional quality of life in these patients. So all these are issues associated with osteoporosis and fracture. Coming to diagnosis, how do we diagnose this thing? Already we have discussed something about BMD. Let's see more. So BMD is bone mineral density. WHO has defined this thing according to these cutoffs we have already seen. So T score means when you compare this score of bone mineral density from 30 years of age. That from if you're taking that point as reference point, then is T score. If you take age matched person, normal person, then it is G score. So what we know that peak bone mass was at 30 years of age. So we'll compare from there only. If it is more than if it is normal is like if it is more than -1, it is normal. This if you see this is normal, and then osteopenia or low bone mass is -1 to -2.5. Osteoporosis is less than -2.5, and if there is presence of any action with less than 5 of T score, then it is known as severe or established osteoporosis. Now remember one thing: if we see 1, 2, 3, 4, these four classes, I say most of the people in this world will be in this category. Less than that will be in this category. Then less than that will be in this category. And then less than that will be this. Why I'm saying so? Understand this. That if the number of people in osteopenia class is more, and if the incidence of fracture is even less, absolute number will be still high. So what do I mean to say? That 50% of fractures that we observe in our patient will be having osteopenia or low bone mass. They need not necessarily having osteoporosis. They can have this fracture, and once they are fractured, anybody is having a fracture uh, with trivial trauma, or they are labeled as osteoporosis, irrespective of PMD. T score reference point is 30 years old white female. Then G score to be used when less than 50 years of age we are using. So if somebody is having 48 years of age, you see the G score, what G score they're having, you can use that G score for this classification in these categories. Somebody is having 58 years, look for the T score reference point. So now we are using BMD. Now understand this. BMD is not a very good thing to measure bone quality for many reasons. For many reasons. Let's see what are the problems associated with that. So if you understand this BMD, bone mineral density is actually mentioned, expressed as gram per centimeter square. So you are taking it only in two places. Body is 3D. We are taking 2D. We are not taking one dimension. So actually we don't actually correctly know what is the BMD. This is actually rectifying it, or let's say adjusting it. So correction, whatever is done by DEXA machine is actually only partial. If it is only partial, then thin and slim patients firstly will show low BMD. So this can be a problem with machine. Then there can be lots of osteophytes. Like in case of old, most of our osteoporosis people will be old only. They will be having lots of osteophytes in their spine. And if you see, then they will be show high BMD. It uses T score and G score. So now, what is the problem with using T score and G score? You are not using BMD, and when you're the comparison becomes difficult because some patient having a minus 2.5 of T score will not have minus 1.5 like next time, or will not have minus 1. It will not like with that. So follow will be difficult. And then uh, in case of DEXA, we are preferring sites like hip, spine. Now, what happens if suppose you have to choose one site? You have to choose one site. Suppose patient is telling, I don't have much money, just I can go only for one test. Tell me, sir, which side? Then you should actually ask patient to get a hip done. Why? Because BMD at hip will only correctly identify the risk for hip fracture in future, and it is the hip fracture which is associated with increased mortality more than the thing. In case of perimenopausal and young patient, you go for spine. Why? Because spine is the site which is to be involved. It means if you do a DEXA scan on spine, it will be most sensitive. And then suppose if hip you cannot do, spine you cannot do, you have to go for forearm. Now understand this. When people fall front side, they will have Colles fracture. That Colles fracture is radius, right? But when you do DEXA scan, you're doing actually in forearm. So forearm, where you choose the middle one third. Middle one third of both bone is taken, and that is the site where you are doing this DEXA scan. So in case of in Harrison, it is written that you go for DEXA at hip, DEXA at spine. That is, but actually it is. So this is this figure from Harrison showing same thing only. Like what they're telling that if you will take G score and this O actually will be missing. So if G score is -1 at the 60 years of age, it is actually square minus 2.5. The point is at years and more of that you have to take T score, and before that you can take G score, and definition is based on T scores only. Now we are discussing only about BMD, and DEXA. Are there any other methods? Because understand this, bone marrow density is only one aspect of weakened bone, only one aspect of porous bone. That actually will not reflect completely on the increased risk of osteoporosis. But still, are there any other modalities which improve the bone? This is a new topic, and this is actually being asked in many papers. They have asked about this thing. I'll just tell you the names of these things, and then you can read further about that if you want to. So there are more techniques to look for bone quality. So BMD already we discussed. Then there is trabecular bone score. So trabecular bone score is known as TBS. It is derived from DEXA images. So what happened? DEXA images, there will be trabecular pattern will be seen, and how they are um, uh, on the basis of that they will give a TBS score. Then there is a high resolution peripheral quantitative CT, also known as virtual bone biopsy. If you do that, you also can understand, by doing so, you can understand the quality of bone. Then there's something known as finite element analysis, FEA. It combines data of peripheral CT with biomechanical properties of bone like stiffness and plasticity. Also gives the idea of bone quality. You can also nowadays use high resolution of MRI for bone. There is something known as micro indentation techniques. So what they do basically, let's see, bone material strength is measured on anterior tibia with an instrument. Indentation distance increase is measured. So what happens? They will give a small nick in front of tibia. They will insert that instrument and they will indent that tibial bone. So what will happen? If bone is normal, there will be less of indentation. If bone is osteoporotic, there will be more of indentation. So this is how they're doing it. So all these techniques can be used to look for bone quality. PMD is not a good modality to look for the quality of bone, but yet it is quantitative. Current scenario, current guideline is to use definition for defining osteoporosis. Apart from these, we can directly go for a bone biopsy and we can see what's going on there. So indication for DEXA, whatever given in Harrison is main indication of DEXA from NOF guidelines, the National Osteoporosis. Okay, and these guys, I will show those also. And this I'm showing is from ISCD, that is International Society for Clinical Densitometry. There are 8 indications for DEXA. So all women more than 65 and men more than 70 can undergo DEXA scan. All post-menopausal women with more than 50 years, women and men with more than 50 years risk of osteoporosis. Uh, just a minute. Okay. So all women more than 65 years of age, men more than 70 years of age, all postmenopausal women has to go, and more than 50 years of men with risk of osteoporosis. Now understand, being postmenopausal is a risk factor for osteoporosis, right? So more than 50 years of age, generally 50 is the age where when women will be having this attainment of menopause. Then adults with fragility fracture, adults with condition or medication associated with low bone mass, anyone plan for treatment for monitoring of treatment, anyone not on treatment who might be benefited with treatment for low BMD, and post-menopausal women discontinuing estrogen. All they are 8 indication for this thing. Now coming guideline, enough indications. So they have given 4 indications. If you see all both things are same only. Uh, Women aged more than 65 and man aged more than 70, regardless of clinical risk factors. Younger postmenopausal women in the menopausal transition, and men aged from 50 to 69 with the clinical risk factor for fracture. So these two are same like of ISCD. Adults who have fracture or at or after age 50, so I think they are likely like this fractures. And adults with the condition like more than 5 mg equivalent for 3 months associated with low mass or bones. So practical points are anybody, any female more than 65 years of age, any man more than 70 years of age, and below that, if anybody is having risk factor for osteoporosis or any drug intake or any condition which can be associated with osteoporosis can undergo DEXA. Now, there are indications for vertebral fracture assessment. So, why there are indications? Because understand this: most vertebral fractures are asymptomatic. People will develop some asymptomatic loss, some will develop in long term, some kyphotic changes, some scoliotic changes, and then they will come to know about vertebral fracture. This is the most common asymptomatic. Being asymptomatic is out of presentation of vertebral fracture. So, this is the reason why there are indications for vertebral same given everywhere. All women age more than 70 and all men or hip or less than 1. Then women this has to be actually -1. Women aged from 65 to 69 and men aged from 70 to 79, if BMD score at anywhere is less than -1.5. In case of postmenopausal women and men with the age more than 50 with specific risk factor. So they have given 4 factors. Like if there is a low trauma fracture during adult, that is same as fragility fracture. Historical height loss 4 centimeter. Now this historical height loss they have taken from their if you is taken from current height compared to peak height during childhood. Then prospective height loss centimeter, and then recent or ongoing long-term steroid treatment. So these are the patient where you vertebral fracture. Now, how will you see? How will you see? So vertebral fracture assessment mostly is done by modified kinetic visual semi-quantitative system. For this thing, you need simple radiograph. The figure from one of the rheumatology textbook. There are 3 kinds of deformities: wedge deformity, biconcave deformity, crust deformity. So simple as name is suggesting, in wedge there will be entry portion is wedged, biconcave middle portion will go, and the crust deformity the last portion will go. Mild, moderate, and severe deformity. So semi-quantitative system is there. You can tell the grade, you can tell the type of deformity. This is known as modified visual semi-quantitative system. Apart from these, there are some other algorithms which are not commonly used. Now, understand this. We have looked for BMD, that is bone mineral density. But BMD is one aspect of having increased risk of fracture. There are still other factors which will lead to increased risk of fracture. Look beyond BMD. If we want to look beyond BMD, we have to have more variables into picture. I am going towards FRAX actually. So BMD is not the only factor deciding fracture. So various algorithms have been developed. Most commonly we are using is this FRAX one. Apart from that, there is something known as Garvan fracture risk calculator, GFRC, and this Q fracture. You don't need to go into detail of these two, but FRAX, yes, at MD level, you should know. So FRAX score is actually calculating 10-year risk of major osteoporotic fracture of more than 20% if it is there, and if fracture risk is more than 3%, then treatment is warranted. Why only FRAX score is talking about 10-year risk only? Why not it is talking about the lifetime risk? You will see subsequently. Traumatic fracture, what this NOF has defined, most commonly in the spine, hip, distal radius that we are seeing commonly clinically, but may also occur in the humerus, pelvis, ribs, and other bones, depending on clinical scenario. So algorithms came into picture because it was missing so much. Coming to FRAX, the with that BMD might not capture all the risk of osteoporotic fracture, and hence FRAX was device which determined the risk of major fracture for the next year. Why? Because there are 3 causes for this thing. Why only 10-year risk is being captured? First thing is treatment is not given for lifetime. So when once osteoporosis is diagnosed, we are not treating them for lifetime. We treat them for a short span of time. Second thing, clinical trial experience of intervention. So even if we do trials for drugs, we will not follow them more than 10 years, and that's how we'll know the exact effect of our intervention. And third thing is some risk factors of time. Like suppose somebody is on steroid, it is highly unlikely that patient will be there on steroid for like 10 years. He'll be there for like 1 year, 2 years, maybe 3 years. So these 3 reasons are there why only we are capturing only 10-year risk in FRAX algorithm. So these are component of FRAX. I may not tell you whether to remember all these, but if you remember all these, actually good, because you see all these are common: age, gender, height, weight, tobacco, alcohol, smoking, alcohol, steroid, previous fracture, parental fracture, secondary osteoporosis, RA, and BMD. All these are actually, if you see, they are predictors of your. Now, you go to this site, the same kind of picture will be there, and you fill your these variables value, and then it will give you a risk factor here. So major osteoporotic risk factor, and there will be a hip fracture risk factor. Suppose if major osteoporotic risk comes more than 20%, and hip comes more than 3%, or then so now we are using all these components in Frax, and we have devised Frax because BMD was not sufficient to capture everything, but still with Frax that we should see. No count of quantity of many factors. Like smoking is there, yes, smoking is there. How many cigarettes per day, BDs per day? Yes and no. But how much steroid we are taking? No, we don't know. And we all are aware that all these factors have a quantitative relationship with the risk of osteoporosis. No account of ongoing treatment. So there is no column for treatment. Somebody might be getting teriparatide. Somebody might be getting bisphosphonates, or somebody might be taking calcium vitamin D. Somebody might not be. Then is not included like vitamin D, bone markers, risk of fall, and protected physical activity. So these are not there, and all these are determinant of the risk of fracture. Country and ethnicity data are not there. Data from there is there, and that only other than femoral cannot be BMT cannot be utilized. So they have given column for, and secondary osteoporosis causes are not very well addressed because they in these 12 points only 3-4 points are there which are for secondary osteoporosis, and many other factors are missing. So approach to osteoporosis, this time is one um, paragraph is there, and then they have whatever they mentioned, we try to make a uh, simplified chart. So work osteoporosis is required when there is a perimenopause transition or height loss or fracture. Whenever there is a fracture, always try to look in old age pregnancy. In case we can rule out either if it is a bone malignancy, we can go for CT, other scans. So fracture is there, other causes of fracture. It is quite possible that osteoporosis and malignancy are coexisting, right? Then we go for basic tests: CBC, LFT, KFT, serum, and urine calcium. And urine calcium actually will help you out. Let's say serum calcium. Suppose if serum calcium is high serum calcium, then you go for PTH. If high, it is mostly because of hyperparathyroidism. If low, it's malignancy associated hypercalcemia, and if there is a high HRP, then hemoglobin malignancy is there. These are the cause hypercalcemia in osteoporosis. Suppose there is a low serum calcium. Mostly calcium will be low if there is a malnutrition or malabsorption. Then you look for these causes, like some GI causes are there, celiac disease is there, something else is going on. Just see for that thing. Now go to urinary calcium excretion. So it can be low, high, or normal. Low is when there is a less than 50 milligram per 20, less than 50 milligram for 24-hour calcium in urine. Before doing this urinary calcium excretion, at least a week before estimating this urinary calcium. And suppose if it's a reduced urinary calcium excretion, mostly because of malnutrition or absorption. Now, suppose somebody is having a high calcium excretion, more than 300 milligram, then there can be 3 calcium leak. Renal calcium leak, the cause for which is released in males with osteoporosis, or there can be absorptive hypercalciuria, means more calcium absorption, so more calcium excretion. Generally associated with high vitamin D, generally seen in granulomatory diseases like lymphoma or sometimes TB, sarcoidosis. These are the causes. Or can be excess bone turnover, like malignancy is there, Paget's disease is there, hyperparathyroidism is there, or hyperthyroidism is there. So all these the basic tests will help you to understand some other cause, mostly malignancy, malnutrition, and all the bone turnover will be captured. Additional tests depending on your findings. So low BMD, always go for vitamin D 25 hydroxy vitamin D level. Hyperthyroidism TSH you can check. Cushing's, go for urinary free cortisol, or you can go for a fasting serum cortisol after overnight dexamethasone. Bowel disease, malabsorption, malnutrition, look for CBC, serum cholesterol, serum albumin. If everything is low, then mostly we are dealing with malabsorption. Myeloma and other infiltrations are there, go for a bone marrow biopsy. And if there is a possibility of CKD-MBD, that is chronic kidney disease, mineral and bone disease, chronic kidney disease associated mineral and bone disease, then you go for bone. So nowadays, whatever bone diseases are occurring with the CKD, they have given a common term of CKD-MBD. Now coming to biomarkers. So understand this: biomarkers or bone resorption markers. Serum bone specific ALP, alkaline phosphatase, serum osteocalcin, and serum phosphatide of type 1 procollagen, bone formation biomarkers, and urinary level of cross-linked N-telepeptide or C-telepeptide are taken as markers of bone resorption. Best time to measure any biomarker, it is 3 to 6 months post-intervention. And if you have to do one test, go for this P1NP. P1NP is nothing but this polypeptide of type 1 procollagen, because it is the most sensitive biomarkers. Why do we need biomarkers? See, the thing is, they are fast and easily changed in disease state, because if you go for imaging like BMD scoring or something else, it will take at least 18 to 24 months to show changes. While marker will take only 1 week or max 1 month. But the demerits, like highly variable, different will different levels of normality, and even the normal, and all these markers had to be collected with empty session also. So problem is standardization. Because of that, now that much biomarkers. But classification, this is not that they should know that nowadays when any marker is there in the picture, in the literature, they would like to see where it fits. So BIPET stand for burden of disease, investigative, prognostic, efficacy of intervention, directive. So means any biomarker can be either one of it or maybe belonging to one of the classes. So markers generally, what Harrison has given are less markers. They have given only bone formation and bone markers of bone resorption. Markers for other things: markers for bone formation, bone resorption, osteoclast number markers, cathepsin K and formation markers, annual inflammation. So all these markers do practice also in classes. So this will be useful there. Now coming to treatment, do you want break of 5 minutes, or like we can go?
I think we can continue, Devender. It's a continuation phase only, so I think
Okay,
it should work.
then,
Yeah.
okay, okay. So coming to treatment. Now we will go first with the measurement of fracture, because fracture is urgency. So generally fractures, there will be either hip fractures, long bone fractures, or there will be vertebral rebar paralysis. So in case of hip fracture, we generally go with open reduction and internal fixation with pins and plates. You can go to hemiarthroplasty or total arthroplasty depending on the condition of the patient and the condition of the bone. Then in long bones, generally we go with external or internal fixation. In case of other fractures, generally it is supportive measures. With pain, you can go with NSAIDs, narcotic agents, calcitonin, vertebroplasty or kyphoplasty. In case of vertebroplasty or kyphoplasty, what we do, we go for injections. This polymethyl methacrylate in that vertebral body, and that provides some support. Short, soft elastic style brace we can provide, and if there is muscle spasm, we can go for short course of muscle relaxant, because they are not indicated for long-term therapy. So this injection of this PMMA in case of vertebral body, there are some side effects. There can be acute extravasation of this cement material into that cavity, and there can be neurological impairment. And there can be increased risk of adjacent vertebral fracture due to increased rigidity, because bones have some stiffness, some elasticity. That's how it adjusts for the stress. Providing this cement will lead to stiffness of this thing, and it will be easier to crack down. Then apart from this fracture management, what we can do, we can go for risk factor reduction. So we can review the medication of patients, some this thyroxine higher doses for longer time, or maybe taking steroid in higher doses, something like this, or anticonvulsant, 2, 3 kind of medication they are taking. Then smoking cessation is important. Alcohol abuse treatment is there. Reducing risk factor for falls, like if they have some kind of refractive error, provide better spectacles to them. Environmental safety is important, like slippery floors are there, or there are no railings. All these can be adjusted. Hearing and vision assessment can be there, and neurological impairment to be addressed if dementia is there or some other problems there. So coming to nutritional recommendation, this data is from mostly Institute of Medicine data, IM data, and they have given age-wise cutoff for what and how much calcium has to be taken daily. So for young children, it is 500. Older children it is 800. Adolescent and young adults 1300. Men and women 1000. Men and women 1200. And they're telling that for pregnancy lactation, same as for non-pregnant. Now, see, because we were discussing already that calcium, which is being provided through these tablets, shell call, and all these carbonates are there, everything is there. There is there is a slight possibility that there can be increased risk of cardiovascular calcification. So, in that scenario, it is the milk which is the best source. So, 8 ounce, that is the or 250 ml of skimmed milk, will provide you 300 milligrams. This is how you calculate how much calcium is being taken by the patient. Then, apart from this milk, yogurt, cheese is there. Then non-dairy almond, rice, soy, they can non-dairy milk can be produced by these sources. Then fortified foods such as certain cereals, waffles, snacks, juices, and crackers. Various vegetables and fruits, this kale, broccoli, dried figs. The problem with these things is there will be lots of fiber, and then variable bioavailability will be there. So whatever calcium is there might not be absorbed. Then these are the different kind of preparation: calcium citrate, lactate, gluconate, carbonate. Mostly we are using calcium carbonate. We have to give less than 600 milligram per dose to enhance absorption. So what acid is required for absorption of calcium? So generally, when you take food, then after food you take your calcium tablet, because when you take food, your acid release is activated, more acid in the stomach, and then you take tablet and it will be absorbed. But if you take lot of calcium altogether, then what will happen? They will be neutralized from the acid, and once acid is neutralized, it will not be absorbed. So this is why they are telling that if you take this calcium, then should take less than 600 milligram of per dose to enhance absorption. Then with food, as acidity enhances absorption, supplements can be taken at any time, because calcium citrate, this citric acid, malic acid is there. They already have their acid with them, so they can be taken empty stomach also. To confirm bioavailability, what we can do, we can take this tablet and we can put into distilled vinegar, and they should dissolve completely in 30 minutes. If they are not dissolving, then something else, impurities are there. Side effects most common, generally there will be irritation, that is lots of, and then constipation. If history of renal stone is there, check 24 calcium excretion. If it is more than, mostly to avoid this thing. Supplemental calcium increase risk of heart disease, conflicting results, already we have discussed. Coming to vitamin D. So there are two different versions of vitamin. Medicine has mentioned only one, but actually there are two different recommendations. In Harris of endocrinology, they have mentioned the other one also. This is recommendation by institutional, how much vitamin D is required per day. So what they have mentioned is less than 50 years, 200, to 70, 400, more than 70, 600, upper safe limit is 4,000 units per day. They want a target of 20 nanogram per ml serum level. And endocrine society recommendation is a little bit higher doses. First year of life up to 1,000, children 600 to 1,000, and adults 1,500 to 2,000 international units. So understand this. Follow endocrine society recommendation, since IOM recommendation was based on population model considering normal vitamin D levels in adults and children. And we know we don't have normal vitamin D levels in adults and children. This is your practical tip. Now, 1 microgram of vitamin D is equal to 40 units of vitamin D. Many tablets will be mentioning only microgram of vitamin D level. Then 1 liter human milk. So what happens? Now understand this. Many many infants will suffer from this rickets, right? Because they have low vitamin D. Generally, for the first 6 month, it is the exclusive breastfeeding that is going on there. Unless mother is on vitamin D more than 4,000 units per day, 1 liter of human milk will contain roughly 25 units of vitamin. That is actually too low, and 1 liter human milk is too much. I don't think baby can drink that much today. So the point is that all babies are being provided vitamin D. Also, they will give vitamin D syrup to them. So this human milk also is not a good source of vitamin D. Always say that धूप में जाओ, बाहर जाके बैठो, go outside and sit in sunlight for this thing, vitamin. But as such, there is no recommendation for duration of adequate sun exposure. You have to sit completely naked, partially naked, morning, evening, and for how much time? Nobody knows. Okay, other nutrients. So vitamin K status is generally is important in case of patient malnutrition, patient suffering from malnutrition, or patient having kind of on therapy, or then magnesium is important in case of malabsorption, malnutrition, or hypomagnesemia because of urine defects. Then cola intake is controversial. There are studies which show that if you take excess cola, then there is increased risk. There are studies showing no risk. So then avoid. And then excess coffee intake. So normal coffee intake generally does not happen anything, but excess coffee intake can have problem. Coming to exercise therapy. So exercise therapy may prevent bone loss, but minimal effect on bone mass gain. Specifically in adults, there will be very little bone mass gain. And but thing is with exercise, there is improved coordination. So when you chances of infecting injury is less. Improve muscles. Go for exercise outside. They will be socialized, less depression, less dementia. Walking, dancing, like gym equipment are also recommended. Everything can be, all of these are recommended to be done. Coming to pharmacological therapy. So far you're talking about non-drugs. Let's see what are the drugs. First, the indications. So BMD, if somebody with BMD less than 0.5 T score, fracture with the if somebody has fracture with BMD less than -1, when low bone mass is there, then also you treat. Frac score, major osteoporotic fracture risk more than 20%. Frac score, hip fracture risk more than 3%. If any of this is there, and sometimes in special scenario, if clinician feels like that treatment is warranted, then also treatment can be given. So coming to therapy, there are anti-resorptive drugs, there are anabolic drugs. Anti-resorptive drugs include HRT, that is hormone replacement therapy, and then there are SCRMs, bisphosphonates, denosumab, and anabolic drugs, teriparatide. Harrison is mentioning that abaloparatide and romosozumab both are FDA's approval is awaited, but in 2017, abaloparatide and romosozumab 2019, they both have got their FDA approval. Coming to therapy with oral as well as transdermal. Orally, generally, if you go for esterified estrogen, 0.3 mg per day, conjugated is 0.625. Ethinyl estradiol is required low, 5 mics per day. And transdermal, if you are giving, then patch should release at least 50 mics per day of estradiol. So data on efficacy. So this table is important. Understand this because there is see in the findings of different studies. So when we see several look for vertebral fractures, non-vertebral fractures, several different studies, small studies have shown decrease in both, more in vertebral, less in non-vertebral, but both yes working. Coming to her study, heart and estrogen progesterone replacement study. So this is the study which has not shown benefit of hormone therapy on bone mineral density. No benefit in any of the features, including hip fractures. But then Women's Health Initiatives trial was there, where they have given estrogen plus progesterone also. They also given estrogen only. And this study has shown reduction in vertebral fracture as well as non-vertebral fracture by these numbers. Then there is this osteoporosis risk assessment observable cohort is there, NORAC cohort is there. Women who used HRT for 5 to 10 years after menopause and then discontinued its use had no greater bone density at the heel or radius at the age of 70 years who never used HRT. So, what is the message from this thing? Overall, this therapy reduces both vertebral and non-vertebral fracture. This is the message. And therapy is more effective if started early and effect weans off completely after 10 years of discontinuation. Remember, we already discussed at menopause, the rate of bone decline increases 10 times. Then, at that time, if therapy is provided, then probably it will work better. Now, see from this thing, at 70 years of age, there was no residual effect. That means whatever effect came for some short time and then it weaned off. So, and in this women's health issue study, we see both the arms have shown reduction in vertebral and non-vertebral fracture, and also other effect. Only her study has not shown any benefit. So, two messages that you should take from this table is first, overall reduces both vertebral and non-vertebral extraction therapy and more effective if started early and effect weans off completely after 10 years of discontinuation. Now, see, this is important because this figure from Harrison is showing effect of both E plus P, estrogen plus progesterone combined, and what they have seen benefit, no effect, and the risk. So you see the risk increase of CSD, stroke, breast cancer, and colorectal cancer and hip fracture actually improved. And there were no effect in endometrial cancer and deaths. When they have taken only estrogen only arm, no increased risk of heart attack or breast cancer. So when they are taking E plus P and when they are taking E only, effects are different. These two messages you should remember from this WHS study. Progesterone is bad for heart and breast. Estrogen is bad for endometrium. This you will again see in further SERM studies. Progesterone is bad for the upper half body. Estrogen is bad for the lower half. Progesterone will increase risk of heart disease and breast. Estrogen will increase risk of endometrial cancer. Okay. Now, this table is showing all whatever mentioned in Harrison, everything in two pages. Everything I have compiled here only. So, selective estrogen receptor modulator. Already should know that estrogen have ER alpha, ER beta, different receptor in different tissues. Generally, these drugs will have variable effect in variable tissues. Generally, triple B, bone, then your blood, and then your breast. It will have better effects. So we have tamoxifen, we have raloxifene, digoxifene, lasofoxifene. So these are four agents that you should know. Lasofoxifene is not mentioned in that. Uh, let's see FDA approved for osteoporosis. Tamoxifen actually can reduce both vertebral fracture as well as non-vertebral fracture. It is good for breast, but it is bad for endometrium. So tamoxifen is like a cousin of estrogen, and that is why it increases risk of endometrial polyps when given for breast cancer patients, and then subsequently there's increased risk of endometrial carcinoma. This is now only approved only for your breast cancer patients and not approved for osteoporosis patients. Raloxifene can reduce vertebral fractures, but the efficacy for non-vertebral fracture is not known. It is good for breast and endometrium both because it does not have effect like tamoxifen, no increase of endometrial cancer. That's why it is good for both breast and endometrium. But problem with raloxifene is when it is given in patients more than 70 years of age, it has high thrombotic events. So that is why generally, if at all, generally old age people will not be given. Then coming to digoxifene, it is exactly same like raloxifene, but the thrombotic risk has not been known. And lasofoxifene, if you see, lasofoxifene, non-vertebral fracture, vertebral fracture, both reduction has been See, it is also good for breast endometrium. Its FDA approval is pending, but it is approved. So this is the summary of all the SCRM agents. Coming to bisphosphonates. So bisphosphonates are pyrophosphate analog with two side chains. They will be R1 chain and R2 chain. R1 will be for bone anchoring, and R2 will be deciding drug potency. And classification is basically first, second generation ET, PAI, and ZR. This is ethidronate, telludronate, then PAMI, alendronate, ibandronate, zoledronate, and risidronate. And mechanism of action, simple. Substituted at the place of POP becomes PCP, resistant to osteoclast mediated resorption. Also, second and third generation of these containing nitrogen side chains inhibit the enzyme farnesyl pyrophosphate, inhibiting protein. So remember this: treatment of postmenopausal osteoporosis and prevention of postosteoporosis. All these four agents are, and this becomes like जरिया. So osteoporosis से बचने का जरिया है कि ZRIA. Remember these drugs in this sequence only because it will be helpful in remembering the next table. So for case of treatment steroid-induced osteoporosis, ZRA is approved for prophylaxis only ZNR, and for men ZRA. Now see this table. So ZRIA, Jaria, ranking of anti-resorptive potency. First is zoledronate, second is risidronate, third ibandronate, fourth alendronate. Now doses, generally zoledronate is given IV, 5 mg every 12 months over at least 50 minutes. It is given as IV preparation in 100 ml of, it comes like powder only. You mix it in 5 ml of saline and then mix it in 100 ml of saline, and then you give infusion over 15 minutes. Risidronate 5 mg you can give, 35 mg per week you can give, 150 mg per month, 75 mg per day for 2 consecutive days. Once monthly you can give. All of these bisphosphonates, they are single. Generally, we give them weekly or monthly when as indicated. Ibandronate oral can be given 150 mg per month, IV 3 mg every 3 months over 15-30 seconds. Then alendronate 10 mg per day, 70 mg per week. We are giving 70 mg per week only. Now see, reduction of non-vertebral fraction of fracture. For everything is proven except EBA has not demonstrated reduction of non-vertebral fracture, reduction of hip fracture. Not demonstrated except in post hoc subgroup analysis of high risk patient. Hip fracture not demonstrated. Otherwise, for everything is demonstrated. Basically, vertebral, non-vertebral, and hip. Okay. So comments. Zoledronate benefit is IV dosing with longest dosing interval. Then risidronate added convenience, monthly oral dosing. We can go for a monthly single dose. Then two dosing forms with long intervals. IV dosing benefit patients unable to use oral bisphosphonates, and alendronate, cheapest, inexpensive generic formulation available. Precautions. So alendronate should be taken with full glass of water before breakfast, after an overnight fast, as bisphosphonates are poorly absorbed. Contraindicated in patients who have stricture or inadequate emptying of the esophagus. Patients should remain upright. They can sit also, standing or sitting, for at least 30 minutes after taking the medication to avoid esophageal irritation. Food and fluids other than water be avoided for the same direction. Now remember, all the trials of alendronate, none of the trial have shown increased risk of esophageal infection, but this is a very, very well known side effect. That is why it is told so. Then adverse effects, non-specific musculoskeletal pain can occur after bisphosphonate dosing. Then there can be mild hypocalcemia. Then renal toxicity can cause also, and then should not be given. They are contraindicated if GFR is less than 13 per minute. Risk of arterial fibrillation. When I was I was a PG student at that time, we used to read that risk of arterial fibrillation is high with bisphosphonate. Now, New Harrison is telling that lots of data has come. It is not proven. So now, these bisphosphonates, they are not associated with risk of arterial fibrillation. That's why I've cut it. Coming to special adverse events. So one is osteonecrosis of jaw, ONJ. It usually follows dental procedure in which bone is exposed, dental extractions and implants. Exposed bone becomes infected and dies. and it is more common among cancer victims receiving high dose of bisphosphonate. At our center in Jimmer, we have given like thousands of bisphosphonates. We have never seen any patient developing any kind of complication like this. For when patients are given in cancers or for skeletal metastasis, then it is higher, and it is rare among persons with osteoporosis on usual doses of bisphosphonates. Generally, when it happens, then oral antibiotic releases and oral systemic antibiotics may be used. Atypical femoral fracture. Now, first see what is now see this figure. Remember, any patient on bisphosphonate therapy, if complaints of any kind of thigh pain or groin pain, you have to exclude presence of atypical femoral fracture. On in this figure, if you see this, see there is little elevation here. This is not smooth, right? It's not smooth, right? Uh, so one lucency is there here and here. So now I'll fracture. So any patients on bisphosphonate therapy developing thigh pain, groin pain are the patient who should be screened. And this is the criteria, major criteria, minor criteria. Harrison has mentioned only the name, but not the criteria. So this is the criteria. All major criteria should be meeting. Minor criteria may or may not met, and then there are exclusion criteria. So now understand these points. First point is proximal fracture line under the lesser trochanter and distal fracture line above the femoral condyles. No trauma or low energy trauma. Transverse or only slightly oblique fracture line means angle should be less than 30. Non-comminuted fracture. Complete fracture crossing from one cortex to the other with or without a medial cortical break, or incomplete fracture or fissure involving outer cortex. And these are the minor criteria. Along the lateral cortex that will lead to some weak, increased cortical thickness, prolonged pain in groin or thigh, bilateral fracture, delayed healing. Okay, and these are the exclusion criteria: femoral neck fracture, intertrochanteric fracture, basically other fractures will be there. Now, see this thing. So, what formation of this fracture line, and when there's thickening of the bone around that, it leads to beaking, and that beaking is generally seen in the lateral cortex. Now, important difference, important DD of this atypical femoral fracture is your stress fracture. So, generally, your stress fracture will be seen in young athlete, while your atypical femoral fracture will be seen in old osteoporosis patients. And this will be on medial aspect of third of femur, but it will be seen generally on the lateral aspect. So there transverse, these are features what will be seen in case of atypical fracture. There will be transverse fracture line or little oblique, cortical thickening, focal or diffuse, particularly in the lateral cortex. Focal cortical thickening may produce an appearance of cortical beaking or flaring adjacent to transverse fracture line, like here. And in a complete fracture, an oblique component will spine. So if groin pain on bisphosphonate therapy, you have to always look for atypical fracture. Always look for the other side involvement because it is frequently bilateral. If you do a radiograph and it is normal, go for other imaging modality. Like you can go for a bone scintigraphy, or else radiograph might miss it. Okay. Coming to calcitonin. Calcitonin is right now approved for FDA for Paget's disease, hypercalcemia, and osteoporosis in women. It is available as injection or nasal spray. Then it reduces the risk of new vertebral fracture by 33%. But calcitonin lacks data showing reduction in non-vertebral fractures. Few drugs which have not shown in non-vertebral fractures. Shown that there is increased risk of cancer. Early report was the prostate cancer. Then many reports came where multiple cancer risk has increased. As if now it has not been withdrawn for the use, but not being used commonly. Then coming to denosumab, it is anti-rank ligand antibody. It benefits in both vertebral and non-vertebral hip fractures. So meta-analysis what has shown that it improved BMD significantly more than bisphosphonate. Means head-to-head it is better than bisphosphonate treatment. At the lumbar spine, total hip and femoral neck at 12 and 24 months. only one study demonstrated greater osteoporotic fracture reduction with dinosome treatment. So it means overall, if you see head to head, it is better than bisphosphonate. Problem is that whatever BMD patient is gaining with use of denosumab is lost rapidly once discontinued. And that is the reason why when somebody is giving denosumab, should be followed by bisphosphonate treatment. There is no upper limit of treatment like you have to give it for 2 years or 3 years. You can continue denosumab. There are studies where denosumab has been continued for 3 to 10 years. Adverse effects like bisphosphonates. This is also a drug which can lead to osteonecrosis of jaw, a typical femur fracture. So you remember this thing. These two side effects are not only exclusive to bisphosphonates and can be seen with both with both denosumab and bisphosphonate. Then there can be hypersensitivity reaction, hypocalcemia can be there, skin reaction including dermatitis, rash, and eczema. Now, again, when we were PG students at that time, there was a line that there is the chances of increased risk of infection, cellulitis with the denosumab. But now, further studies have come. There is no increase of infection associated with denosumab. Teriparatide. So now understand this. Patients of chronic hyperparathyroidism, they generally develop cortical bone loss because PTH associated bone loss is associated with cortical bones. But if there is a mild endogenous hyperparathyroidism, or let's say there is a pulsating intermittent kind of hyperparathyroidism there, then there will be mild cortical bone loss, but there will be also trabecular bone mass gain. So on this funda, teriparatide has come into the picture. So head to head, teriparatide is better than bisphosphonates. This figure is your Harrison only showing the effect of teriparatide on the risk of new vertebral fracture. Overall, actually works just. This trial is important. This is path trial. This trial is important for one reason. Like this trial has given the idea that sequential therapy is better. Means if you give RH, then it should be followed by bisphosphonates. So if you see in this figure, now see this red thing is parathyroid hormone with placebo group. PTH hormone with alendronate group means PTH they are given first and then they give alendronate group. And then yellow one is therapy. From right from beginning they were giving PTH with alendronate. And then there is green. So if you see, let's see for this figure, the blue is showing the maximum mean in your BMD. It means that when you give PTH therapy and follow this therapy with bisphosphonate, then probably the effects are best. Now, this is a common sense, right? If you give both therapy together, if you give this bisphosphonate along with PTH, we know PTH has to erode the bone, right? And bisphosphonate will kind of cement only, right? It cements the both together. Effect will not be good. Once you give PTH, bone formation increases after mild reduction in bone form, mild this bone resorption, and if it is stopped, then whatever bone was gained will be rapidly lost, like denosumab. So it is always better to provide bisphosphonate. So this trial has given the idea that whenever you give this recombinant PTH, if you follow it with bisphosphonate, then probably the effects are better, best. So happen other way can also happen, right? Somebody was already receiving bisphosphonate and then PTH started. That can also happen, right? So the BMD effects, particularly in the hip, are lower when patients switch bisphosphonate to teriparatide and possibly in proportion to the potency of the anti-resorptive agents. After 12 months of therapy with teriparatide, participants who previously received disodonate show 76% significantly greater increase in the density of trabecular bone at the spine as measured by quantitative CT than did those who previously received electronate. So what does that mean? That means if somebody was not treated in previously untreated women, teriparatide is best administered as monotherapy and should be followed by a potent anti-resorptive agent such as denosumab or a bisphosphonate. Somebody was getting bisphosphonate earlier, and if you give teriparatide, yes, it can still work, but the effect is different. Like the study is showing that effect is better with isotronate earlier compared to alendronate. Indications. So generally, patients with one or more of the following condition are generally appropriate for teriparatide therapy. Those significant decline in BMT during anti-resorptive therapies. Those who are unable to take anti-resorptive agents because of side effects. Those who sustain a fragility fracture during anti-resorptive therapy. Those who have multiple clinical risk factors for fracture. Patients who are treatment naive and at high risk of fracture. So adverse effects, muscle pain can be there, weakness, dizziness, headache, nausea, all these are there. In rodents, they have seen, the studies have shown the development of osteogenesis sarcomas after 18 months of treatment. And rare case of osteosarcoma are known in humans, but remember that the rate was same as at background population rate. So we cannot attribute that we can say that there are increased risk of osteosarcoma with PTS therapy. So maximum duration of therapy is 2 years on the basis of these animal studies with PTH. So if you are giving PTH to a patient, it for 2 years if possible, and after that you start patient on bisphosphonates. Abaloparatide. So abaloparatide is actually synthetic analog of PTHR. I think the beauty of teriparatide therapy when we were giving it was in its transient action, because if sustained PTH will act, if there will be sustained action of PTH, they will be boneless only. So we give injection daily, we are giving pulses, we are giving daily, then that's how bone is being formed. So if it is the reason, then see what happens when your PTH is bound to the receptor, then increase in cyclic like this. Binding of abaloparatide, it binds like this. So it means it is more transient, more short acting, more transient effect is there. This abaloparatide has got 70% homology with PTHRP and less with PTH. It binds more professionally to the RG conformation. There are not an RG conformation of receptor, and is shown to cause a more transient response than does teriparatide. Favors the anabolic effect of abaloparatide with fewer bone resorptive effects. So it means overall, theoretically, it should be better working than PTH. So better drug profile to be given as 80 mg sub-Q in periumbilical area daily, max for 2 years. Indications are same as of teriparatide. And this is active study phase 3 that actually compared versus teriparatide. Similar for spine and hip, better for non-vertebral fractures. So if you see overall, abaloparatide is like teriparatide only and maybe better for non-vertebral fractures. It has been approved. Now coming to romosozumab. So romosozumab is anti-sclerostin antibody. So these are the name of trials you should be knowing. One is FRAME trial. FRAME trial is a landmark trial which came and then we showed that the effect of romosozumab. In FRAME trial, they actually compare romosozumab with placebo and they also give denosumab after romosozumab extension phase. ARCH trial, they compare romosozumab with alendronate, and the BRIDGE trial was done in case of men. So all these trials have actually shown significant improvement in osteoporotic fractures. If you see these cases of ONG atypical fracture, there were no cases, like one cases, or here is one cases. In this FRAME trial, they also give denosumab for a significant time period, and frequency is very low. We don't know whether it can be attributed to romosozumab. The one more trial should know trial. In structure trial, they gave romosozumab in previous bisphosphonate use. So what they did basically, they compared monthly treatment with romosozumab 210 mg resulted in greater average change in hip score over 12 months compared to daily 40. 40 was teriparatide 20 mg injection. So head to head, they compared and they find that this romosozumab was better than teriparatide. The incidence of adverse event was similar between groups. Most common adverse event they have seen is like nephrologitis, arthralgia, back pain, headache, and falls, and there were no any major side effects. Coming to some less commonly used or like outdated kind of therapies, strontium ralate. Strontium competes with calcium for intestinal absorption. That is one point you should remember. Then it is once absorbed also once it is absorbed, it incorporates in bone in place of calcium in bone and dental tissues. At low doses, strontium ralate results into uncoupling of bone turnover by stimulating osteoclastic activity and decreasing osteoclastic activity. When we were UG students at that time in pharma, we used to read that strontium ralate is one of the agents which is both anti-resorptive and bone forming. Adverse effects, mostly nausea, diarrhea, that will be happening in first 3 months of therapy. Pooled analysis have showed increased risk of cardiovascular disease, and reason why there is no further development. Restrict use, if you're using it, restrict use to patients with severe osteoporosis in whom other treatments are not possible. Patients with a history of ischemic heart disease, peripheral disease, uncontrolled hypertension are at high risk for cardiovascular side effects of sodium valent. Coming to odonocardin, uh, now remember this cathepsin K is secreted by mature osteoclast to degrade bone matrix protein, including type 1 collagen. This happens, this formation of bone multicellular, BME formation is there. Odonocardin actually selectively inhibits cathepsin K in osteoclasts and it reduces their resorptive activity, but cells are alive, and there is also paracrine signaling to osteoblast. Oral cathepsin K inhibitor odonocardin 50 mg once a week continuously increase spine BMD in postmenopausal women by inhibiting bone resorption and only transiently decrease the bone formation markers. But it has adverse effect like morphia, like skin lesions are typical for fractures and strokes. In this LOFT trial, the LOFT trial was a trial which has shown the benefit, but the problem was in this LOFT trial there was a increased hazard ratio for the strokes, and because of this increased risk of stroke, the further work has been stopped and it will be withdrawn. Coming to testosterone therapy, Endocrine Society recommends a combination of use of anti-fracture treatment with therapy at high risk of fracture. So, as if now it can be added in osteoporotic men. Monotherapy, if suppose if a patient is there of osteoporosis and somehow anti-osteoporotic therapy cannot be given for contraindication, in such patient, monotherapy can be considered if there are low level of testosterone, like less than 200 milligram per deciliter. Rona Calret. So what happens if you see this parathyroid gland? This PTA, this parathyroid gland is there, which is producing this your parathyroid. So the gland has a calcium sensing receptor, CSR, and that calcium sensing receptor is sensing calcium. That's how it decides when to release and how much to release PTH. So this Rotaret is drug which is working on this. It is an orally administered calcium sensing receptor antagonist that stimulates endogenous parathyroid hormone release from the parathyroid gland. So in randomized trial, when they have done a trial, what they have that seen that can actually increase vertebral bone mineral density of trabecular bone that cortical sites. Preservation of trabecular bone loss at cortical sites are consistent with the induction of mild hyperparathyroidism with donor-carotid therapy. It means this teriparatide therapy, abaloparatide therapy, and the donor-carotid therapy, all these have a similar kind of appearance. Sodium fluoride, generally, if you see, this is outdated drug. Although BMD is increased substantially, but increased fracture risk was not reduced in any of the studies. In fact, some studies have shown that there is increased non-vertebral fractures, and for these reasons, fluoride is no longer considered a viable option for osteoporosis treatment. Coming to statins have been seen to promote osteoclast apoptosis and synthesis activity. It increases synthesis activity in osteoblast, and it also inhibits the mevalonate pathway that lead to increased gene expression for BMP2. And BMP2, as we know, is involved in one of the pathway of bone. If we see, can be a future drug for treatment of osteoporosis. As such, right now, data is not available. Coming to non-pharmacological approaches, protective pads on outer thigh in very old people nursing homes, vertebroplasty or kyphoplasty can be done prior to fracture. But effect of these interventions is not clear so far. Now we have discussed so much about these drug, that drug, it is working like this, working like that. That is all okay. But if a patient comes to you of osteoporosis, how will you treat? Okay, you will tell the patient, go do exercise, don't smoke, take less of alcohol, or don't take of alcohol. You can tell them to do this and do that. Calcium you can take, milk you can take, vitamin D you can take. Now, when it comes to pharmacotherapy, then how will you decide and what to give and whom will be benefit? So, before starting therapy to any patient, it is always good to stratify your patient. Stratification, risk stratification, whether my patient is having a high risk, moderate risk, or low risk. So, this table you understand. This table is dividing your patients of osteoporosis four categories: moderate risk, high risk, very high risk. Now, if patient has history of any fracture, fracture means fracture or osteoporosis fracture. Even if single fracture is there, patient directly comes into high risk, right? Single spine fracture, multiple fracture, very high risk. Okay. BMD at hip and spine, whichever is like lower. In case of lower risk, generally both will be more than your this thing -1. Moderate risk -1 to 2.5, and high risk it will be less than -2.5. High risk will be -2.5. It means if somebody is having BMD less than -2.5 and having one fracture, it becomes high risk. If anybody is having less than -2.5 and multiple spine fracture, it becomes very high risk. 10-year risk of hip fracture from frax and 10-year risk of major osteoporotic fracture from your frax. So in case of low risk, moderate risk, it will be less. In case of this is less than 20%, and high risk, it will be high. So suppose a patient comes to you and patient has undergone DEXA score, and the DEXA score patient's BMD has come uh, 5, and then his frac score you calculated, and this frac score has somewhere, let's say, hip 2%, and this thing the 10%, he will come under moderate risk category, right? Similarly, any patient having BMD T score -3 directly go to high risk. If -3 with single fracture, then high risk. If -3 with multi fracture, very high risk. So this is how you stratify a patient. I am stratifying my patient so that I can decide what treatment should be started. Okay. Now this is from the latest guideline that is not mentioned in the book, but this is the latest guideline. So what you do, how do you do? So all postmenopausal women, what you're doing, you have to make sure of the other non-pharmacological interventions that we already discussed, and then you see whether your patient is a low risk or moderate risk or high risk or very high risk. Now, low risk patient means patient who has like normal BMD and less than 3%, less than 20% of frax cutoffs. Then in such patient, you don't treat actually. And in these patients, you reassess fracture after 2 to 4 years. Moderate risk patient, you can either go for no treatment or for treatment. So what we do, we generally treat patient because we know there are many factors apart from BMT which will increase the risk of fall. It is better to treat. So in such patient, we go with bisphosphonate. In case of high risk, very high risk patient, you can go with treatment by three modes. Either you can go with teriparatide or abaloparatide. You treat them for 2 years because that is the maximum indication, and after that, immediately start them on thing like either bisphosphonate or dinosumab. Right? If you dinosumab is given, then also you have to give bisphosphonate later on because rapidly bone will be lost. Or you can go for treatment with bisphosphonate, or you can. So this is how you treat. Everybody will receive calcium vitamin D without thinking again. Then like here what they're telling, 5 year for oral, 3 year for IV you treat, and then here you can treat for 5 to 10 years or 2 years. So what they're telling, after you assess them and you try to understand whether a drug holiday can be considered. You assess, and if bone loss or patient becomes high risk, then consider recycling therapy. In case of low moderate risk, if risk increase, then consider therapy. In high risk, continue therapy or switch to another therapy. Like you can go for denosumab or teriparatide. Suppose there is an intolerance or inappropriate for patient is not able to take any of these drugs for various reasons, then you see the patient's age, more than 60 years, less than 60 years. If less than 60 years and there is vasomotor symptoms, better go with hormone treatment therapy. Kyun? Why? Because these many of SCRM will increase actually vasomotor symptoms. So you don't give these when there is already vasomotor symptoms. So when there are vasomotor symptoms, you go with your estrogen and progesterone. Hormone therapy, if there is no uterus, estrogen with happens depending on whether uterus is there or not there. They are telling estrogen plus progesterone you can go, or estrogen alone you can go. And here is no vasomotor symptoms and high breast cancer risk is there, then you go with either loxifene, which is doxifene. Now, the lesofoxifene also has come, can be added here. If age is more than 60 years, you go with SCRM, or you go with in SCRM also try to avoid loxifene because there is high risk of thromboembolism. Then calcitonin, calcium vitamin, tibolone. Tibolone is nothing. Tibolone is a drug which has all estrogenic, progesteronic. It has been in all smaller studies, or you can go with hormone therapy. So this is how you decide treatment for your patients. Now, what is drug holiday? So drug holiday is actually associated with bisphosphonate therapy. Now you understand this. When you are giving bisphosphonate to patient continuously, there are three things. First thing is, if you give a therapy for longer times, there has to have some kind of side effects. Now, if you give bisphosphonate, it is kind of cement, right? Once bone is cemented, then somehow, somewhere, there is a problem with remodeling of bone. Once remodeling of bone is affected, then actually bone quality is affected. So that's how typical female fracture is occurring, right? And third thing is, it has been seen that if you give therapy for some time, like suppose you give for 3 years and then you stop for 3 years, or whether you give for 6 years continuously, when you compare, the effect was same. If it is that so, drug in between for some time is actually not hampering the efficacy of drug, then why you should not stop it? And that's how idea of drug holiday has come. So now when you give bisphosphonate, you decide for drug holiday for how much time you will give gap in between. Your patient is high risk, very high risk patient. Treatment duration, low risk, we don't treat, as we discussed in the last slide. Moderate risk patient, 3 to 5 years you treat. A high risk patient has to be treated like 5 to 10 years, and a very high risk more than 10 years. Drug holiday duration not applicable because they were not on treatment. Moderate risk patient, continue your drug after 5. Like if you give therapy for 3 to 5 years, then you continue till fracture occurs, or there is second loss of BMD, whichever earlier. In case of high risk, you go for 3 to 5 years or continue till fracture or significant loss of limb is there. In case of very high risk, drug holiday is short, up to 2 years. You can continue, or you can uh, see for the fracture or the significant loss of BMD, which is earlier. Now, what is this significant loss of BMD? This is not given in the book, but this article which has mentioned drug holiday is telling significant BMD change actually depends on center protocol specific. Why? Because now when DEXA machine works, DEXA machine is a machine is giving some number like 3%, 10 gram, 15 gram percent like giving. So what happens is some random error is there. Like if you repeat the same test for on same machine, can be different values that occurs because of random error. You will be understanding if you read biostats part. If you take my weight now 60 kg, it can be 75 kg, it can be 74.9 kgs, then 100 gram is random error, right? So what happens? Every DEXA machine has got some random error, and every machine has got some least important change. So every machine along with that protocol will be having some range like 5%, 10%, 12%, like likewise will be there, that this much is significant change. So that is center and protocol specific. So if there is significant BMD change, then you can, or this fracture, then you can you adopt your drug holiday and start treatment again in these patients. So what is target for treatment? How long to treat, that we already have seen, but what for treat for what? So target of therapy is to bring T score more than minus 1.5, and when to repeat DEXA. So new Harrison has not mentioned it. In earlier Harrison, they used to tell for 2 to 3 years. DEXA has to be repeated at least more than 2 years, and significant change. What is significant change is 4% in spine and 6% in hip. Means they should be increased in BMD, gram per centimeter square values there. That BMD should actually increase, significant changes, increase by 4% in spine and 6% in hip. Hip is preferred because of larger surface area and better tolerability. So if you, again, like I told in previous slides, if you have to do for one side, go for hip. Young patient for vertebral spine. When you are repeating, you repeat for the hip. You see if there is significant change, like 6% increase in your BMD, then treatment is going on well. And there is no point of repeating DEXA like 6 months, 3 months, 6 months, like this is not required. At least give your therapy 2 years. And if you give therapy for 2 years, and then then you can repeat DEXA if you want. Thank you.